we have more resources now being generated through reimbursement of SHA, and with the facility improvement fund, we now have more resources that are available. But is it possible to direct those resources to employment? At the moment, I don't think the structure allows that. We plow that back to improve the facility. Does the facility improvement include employment? That is a good question we should be asking ourselves on the way forward, because that is also a need.
Thank you, Excellency Governor. Thank you, Excellency Governor. I know time is limited, but I wanted you to comment on the intersection with the county public service boards. There are a number of counties that occasionally we find the county public service boards needs a bit of strengthening, that the advisory role of Service Commission engage so that then service delivery is not interrupted.
The County Public Service Board have played a very critical role in recruitment, in ensuring that we don't just recruit, but to have the right staff with the right skills, and also being placed in the right places. And you are aware that even in the coordination that we have with the national government, the MOH, on this, that we have shared responsibility. Recruitment was by the County Public Service Board, even though the payroll has been domiciled in MOH. Without county the right role, we would be having these workers being somewhere in between, without direct responsibility and supervision. Yes, it is true that we need to kit, or rather to continuously build our capacity for public service board, because they may not currently be at the same level of public service commission. But a lot of work has gone into capacity building, seeing proper interpretation of policies from the MOH, and also in counties also of professional recruitment in the workforce.
Thank you, Excellency. A round of applause for Excellency Governor. Now, on of HRH, before we move to service delivery, we work with WHO at the Ministry of Health, and there are two key documents where the leadership led by Honorable Cabinet Secretary have health professionals policy, and this relates directly to how galvanize of that WHO has had some input to the Ministry of Health. And as you mentioned, the role of WHO in intersecting with national governments that are member states of WHO in establishing policies for health professionals or even health workers. You may also comment on the Health and Care Compact, which is also another tool that involves a framework for enabling countries clean up, let me use the word clean up, the space of health workers, because it's been a big challenge, including the code of practice for international recruitment of healthcare workers, just so that the health workforce.
Thank you very much, PS and Excellencies. I'll stand on existing protocol. So WHO has been working with the Ministry of Health on health workforce with support from the UK government. And I just want to highlight several tools that have been very useful. WHO has a tool called Health Labor Market Analysis, which enables the country to look at the different cadres they have, where they're placed, and look at the needs. And this health labor market analysis helps to look at the training, the production, and all the different cadres that you have and the needs of the country to enable the country to be able to plan for the health workforce. Another very important tool is the National Health Workforce Accounts, which helps the country to really come up with data of all the health workers they have. And prior to using the National Health Workforce Accounts, maybe we had numbers that were just at national level, but now we have detailed data that even counties, all the 47 counties, are able to see all the health workers that they have and where they are placed. And this is important because you're able to see the gaps and you're able to see where it is most important and where the gaps are, so that you place, as you recruit, that you place them in the correct places. And this was what PS Muthoni alluded to, that Kenya was ranked 3rd in the region and 6th in the world in terms of data. Another important tool is the workload indicator staffing need. This helps managers to be able to look at the load that the health facility is covering, what types of patients are coming in, and this then guides them to be able to plan appropriately based on the need of health workers. So we have been able to work with the ministry on this, and for the first, the ministry has now with the health workforce policy and also a health workforce strategic investment. And at county level, 130 managers, HR managers, have been trained on this workload indicator staffing need, which will enable us to plan in ensuring that we put health workers where they are most needed. And this brings in now the African Charter, which aims to ensure that we train, that we deploy, and that we retain health workers where they are needed, and to be efficient in our placement of health workers, because sometimes you can have the numbers, but you may have huge numbers, maybe in Nairobi, for example, and there's duplication, and you have other places which are more remote, which are lacking the services. This health labor market analysis also informs what PS Oluga has alluded to on the International Code of Migration of health workers. You are able to see what is your output, and are you able, countries are labeled according to their production, according to the staffing that they have, to see whether they can export health workers. Now, if you export health workers, obviously was in countries with good training, quality, you would have health workers being taken by developed countries, but the country that has been producing those health workers is not gaining anything. So at WHO, we work with countries to have, as they come into agreement with developing nations, as they are taking staff, that you have an organized migration, but you also get good contracts for those who are going, but also what comes back to the country, because the country has invested in training these people. So if they are going abroad, if you're producing more than you can use, but what is the country gaining? So WHO has been working with several countries, as well as I know Kenya, Ghana, Nigeria, and others in terms of helping countries to negotiate for this organized migration when needed. Thank you.
Thank you, Dr. Neema. Your Excellency, if you allow me, that the issue about the co-investment that WHO talks about is important for Kenya, because I know this is also one of the key agenda of our government. And I just wanted to ask for a roving mic, Your Excellency, just so that we get the numbers from KMTC in terms of nurses and those who are going abroad, so that then we can look at how to engage in this co-investment decision. And this is important for your leadership. So the CEO of KMTC, just a 1-minute comment on those numbers and how they have improved. Please, roving mic, CEO of KMTC is right here.
Thank you so much, Your Excellency. My name is Dr. Kelly. Thank you so much, Your Excellency. My name is Dr. Kelly Oluoch, CEO of Kenya Medical Training College. Your Excellency, in 2022, we were graduating 15,000 students. In 2025, Your Excellency, we graduated 22,076 students. Your Excellency, that is an increment of 43%. Your Excellency, this year we are going to graduate 25,000 students. Your Excellency, one of the efforts that we need and very critical for us is responsible labor mobility. Your Excellency, as an institution, Kenya Medical Training College has created foreign language curricula in German, French, and Arabic, and now Amharic, to support labor migration. What Madam Nema is talking about is critical for Kenya Medical Training College because we are the largest producer of human resources for health in this country and sub-Saharan Africa. So we will want to engage to make sure that we're able to ensure that those we graduate are able to get gainful employment, not only locally, but internationally. Thank you, Your Excellency.
Thank you, Your Excellency. Just looks at some of the gains, and also I hope that our media, you recorded, you know, we are here for reforms that have been delivered. You recorded that Kenya is the 3rd in the world as far as health workforce data is concerned. I mean, the 3rd in the region and the 6th in the world. I'll move very quickly to service delivery. And here I will be asking from the private sector, Dr. Gakombe is here. 46% of the facilities now are private sector. The government has established the enabling frameworks for financing. How do we strengthen performance of service delivery at the private hospital level?
Thank you, PS Oluga, and allow me also to ride on existing protocols. It's true that the private sector is a key provider of care in the country. And because access, achieve quality, and be efficient, one of the key things to achieve that, one of the most enabling features or developments is digitization. Because digitization allows all of us to keep track of what is happening across the entire country. And it allows us to tie all the facilities together, track referrals, and track outcomes, so that we can be outcome-based rather than purely focusing on the infrastructure available. And I want to take us back to a point when we had COVID. During COVID, the Ministry of Health scrambled to find ICU and critical care facilities. Today, that's not a problem anymore because SHA and the Medical Council and the ministry have live data on where that infrastructure is, whether it's occupied, and what is happening to the patients who are admitted in those facilities. Once we link up with the registration service so that we can record deaths and births on a live basis, we'll even go a step further so that outcomes can easily be tracked. So there is a lot that has happened, but one of the most critical is digitization, and the second one is the financing reforms. It's true we had NHIF, it had its challenges, we have SHA, and we've worked very hard to address some of the teething challenges SHA has. But for we in the private sector, payment comes from the patient, and many of them don't have money to pay. So having SHA pay their bills, having private insurance pay their bills, having employers pay their bills, enables more private sector service providers to thrive and grow. And for some of our patients, like dialysis, the only insurer and the only payer for the whole country is SHA. I do not know many places where there is anyone else paying for dialysis other than SHA, and the amount that is being paid is usually what we charge, because many of us are not charging anything beyond the SHA price. So we are keeping people who have end-stage renal failure alive through collecting money and channeling through SHA, and B, allowing private providers and paneling them as providers of service so that Kenyans have more access.
Just 1 minute, a very important thing. So His Excellency the Deputy President has just emphasized what the President mentioned about primary healthcare fund. Counties are here, they have made a lot of investment at that level, level 2, level 3, PHC, 27 billion, 23 billion paid. How do we shift the mindset of the private sector to invest in specialized services? 70% of PHC covered by government. We still do very less transplants. We still do very less cardiac surgeries. How do we shift the mindset of private sector that it is no longer very needed to just open up a clinic, pay very high rent, and Homa, that the government has already invested at the village level? Just in 1 minute.
Our biggest job is to fill whatever gaps are left after the counties and the national government have provided service. So what you're anticipating is already happening. Many of our facilities, including the one I lead, are moving into more specialized care, renal, cancer, heart transplantation, and one of the key areas we are investing in. If you recall, we've had a lot of traffic going out of country for treatment, and it's now policy that Kenyans should be treated here, close to home, near their relatives. And there is the money to finance it. So we are investing a lot more in upgrading care. I myself have brought the first robot for knee surgery in East and Central Africa, and we've already operated on 13 patients who would ordinarily have gone out of the country. And there are a couple more robots that have come in. So as KU does CyberKnife, Aga Khan is doing something else that is also quite specialized. We are doing something else which is quite specialized. And we'll be in Ethiopia on Thursday to tell them what it is that we can provide to them.
Thank you.
We are regional.
Thank you so much. This is very important. And I'll bring in KNH. Yesterday you spoke in the town hall, you mentioned the establishment of the theater. So today, just tell us the outcome, the quality, and perhaps you bring in the technology, because KNH, you mentioned that is digitized for the first time, of course, with the support of DHA. So just tell us, how has that improved? Two things. One, experiences of patients, and number two, outcomes.
Thank you very much, Dr. Oluga. Let me recognize the presence of His Excellency, the Deputy President. Kenyatta National Hospital is the second largest hospital in Africa.